In this video, we will be reviewing the musculoskeletal exam special tests for the knee. I will be walking you through the 8 essential special tests that will be important for both your surgery clerkship and for your future career as a physician, regardless of what specialty you choose to go into. We'll start off with the knee effusion test. The purpose of these tests is to evaluate for knee swelling or effusion. There are 3 ways to test for effusions in the knee. First, the milking maneuver, where you milk down fluid from the suprapatellar pouch and feel for expanding fluid on both sides. The second method is the fluid shifter wave, where you milk the fluid up into the suprapatellar pouch and visualize the fluid coming back down into the knee joint. Lastly, the patella ballottement test, where you tap down on the patella. If there is a large effusion and the patella is floating on a bed of fluid, you will hear a click. With our patient, we will start with the milking maneuver, where you will use your hands to milk fluid from the suprapatellar pouch and feel for expanding fluid with your other hand in the knee joint. In the fluid shift test, you milk fluid from the joint into the suprapatellar pouch and then watch for the fluid returning into the knee joint. And finally, with the patella ballottement test, in a large effusion, if you tap down on the patella, you will feel or hear a click, which indicates a positive test and fluid inside the knee joint. Next, the anterior and posterior drawer tests. The purpose of these tests are to evaluate if the anterior cruciate ligaments and posterior cruciate ligaments are intact, respectively. An intact ACL normally prevents the knee from excessive anterior translation, whereas an intact PCL stabilizes the knee from posterior translation. For the anterior drawer test, the knee is flexed at 90 degrees with your thumbs on the tibia, and you apply a forward or anteriorly directed force. Use the same hand positioning for the posterior drawer test, and apply a posteriorly directed force. With an intact ACL and PCL, you should feel a hard endpoint or stoppage to the corresponding motion. On our patient, flex their knee to 90 degrees, and then make sure your thumbs are below the joint space and resting on the top of the tibia. Apply an anterior force to test the ACL and a posterior force to test the PCL. In our patient, you can see that her knee has a hard stopping point to the anterior and posterior motion, and thus her ACL and PCL are intact. Here is another patient with his knee flexed at 90 degrees. We feel for the knee joint space and place our thumbs below the joint space on the top of the tibia. By applying an anterior force to the tibia, we see that he has an increased anterior movement and no firm or hard endpoint, which indicates a positive test and a damaged ACL. The next test is the Lockman test, which also assesses the ACL but is more sensitive than the anterior drawer test. Let their leg rest in slight external rotation and flex their knee to 30 degrees. With your thumb on the tibia, move the tibia anteriorly, and with an intact ACL, you should again feel a hard endpoint and a stoppage to anterior motion. If you do not feel a hard endpoint and have excessive forward movement, this is a positive test and possibly a damaged ACL. With our patient, let their leg rest in slight external rotation and flex the knee to 30 degrees. Grasp the tibia firmly just below the knee joint and the femur just above the knee joint. As you apply an anterior or forward-directed force on the tibia, you can see that there is a firm endpoint where the tibia stops moving. This indicates an intact ACL and a negative test. Here is another patient's knee. Again, their leg rests in slight external rotation. Flex their knee to about 30 degrees and place your outside hand on the femur just above the knee joint and inside hand on the tibia just below the knee joint. Apply an anterior force to the tibia. We see here an increased anterior movement of the tibia, indicating a positive test and a damaged ACL. Next is the varus stress test. The purpose of this test is to evaluate the lateral collateral ligament. When the LCL is torn, you will get excessive movement with the varus force on the knee. With an intact LCL, you should feel a firm endpoint. To evaluate the LCL, start at 0 degrees of flexion and apply a varus-directed force, and then again with the knee flexed to 30 degrees. 0 degrees, then 30 degrees. On our patient, we test the lateral collateral ligament of the knee by placing one hand on the distal tibia and one hand on the medial side of the distal femur. Apply a varus force on the knee at 30 degrees and at 0 degrees of flexion. In a negative test, the lateral structures are intact and you will see a firm endpoint, such as in this patient. In a positive test, you will have an increased joint opening with the varus force and no firm endpoint. Next is the valgus stress test. The purpose of this test is to evaluate the medial collateral ligament. When the MCL is torn, you will get excessive movement with the valgus force on the knee. With an intact MCL, you should feel a firm endpoint. To evaluate the MCL, we provide a valgus-directed force at 0 degrees and at 30 degrees, and look for excessive joint opening. If the MCL is intact, there should be a hard endpoint to motion. On our patient, we grasp the distal tibia with one hand and the distal femur with the other, and apply a valgus-directed force at 0 degrees and at 30 degrees. And on this patient, you can see there is a hard endpoint and thus it is a negative test. Finally, the McMurray's test. In this test, you are testing for damage to the meniscus, with the posterior horn of the meniscus being the most commonly injured part. In the lateral McMurray, apply a valgus stress and internally rotate the tibia. This brings the posterior horn of the lateral meniscus into the joint space, trapping it between the lateral femoral and tibial condyles. Then range the leg through flexion and extension while palpating the lateral joint line. Here on the patient, we perform the lateral McMurray to test the lateral meniscus. Start with the knee in flexion and apply a valgus-directed force with the tibia in internal rotation while running your fingers over the lateral joint line while flexing and extending the leg. The reason for the internal rotation of the tibia is to bring the posterior horn of the lateral meniscus into the lateral joint space and trap it between the femoral and tibial condyles with our valgus force. A positive test is if the patient has pain with palpation. For the medial McMurrays, apply a varus-directed force to trap the medial meniscus between the medial femoral and tibial condyles. Externally rotate the tibia and flex and extend the knee while palpating the medial joint line. Externally rotating the tibia will bring the posterior horn of the medial meniscus into the joint space. Here on the patient, for the medial McMurrays, start in flexion. Apply a varus force to the knee and externally rotate the tibia while flexing and extending the knee and palpating the medial joint line. Again, varus force traps the medial meniscus between the medial femoral and tibial condyles, while external rotation brings the posterior horn of the medial meniscus into the joint space. A positive test is pain with palpation of the medial joint line, which indicates damage to the medial meniscus. Those are the 8 essential special tests for the knee. And that concludes this video. Thank you for watching.